دايما بتعودنا عليها الدكتوره مي في محاضراتها. اتفضلي يا فندم.
Thank you very much, Mr. Chairman, for the introduction, and I want to thank very much Professor Magdi Sharawi and the organizing committee for inviting me to give this talk. And of course, I'm very happy to be here in this very respectable meeting. The talk today is going to be on thrombotic microangiopathy, and the kidney, not just CPD, and the kidney. And this is a very important subject, actually, and we're going to touch on definitions, pathogenesis, causes, diagnostic approach, and treatment. Actually, it is a histopathologic term which defines the presence of fibrinogen in the glomeruli and the arterioles. And endothelial injury is central because it plays an important role. Actually, it's the exciting role in this problem. And you can have platelets and bile, you can have variation from endothelial swelling to complete portal necrosis, and of course, when there is narrowing of the lumen, there's going to be ischemia of the organ up to complete portal necrosis. So when you have intraluminal platelets and bile, you have consumption of platelets and thrombocytopenia, and also with the flow in this partly occluded part in the sheath stress, there's going to be hemolysis with anemia, increase in LDH, bilirubin, and reduced hemoglobin, which is the microangiopathic hemolytic anemia. So this can occur alone with no systemic symptoms, in which case it's said to be localized, or it can occur in the context of syndromes like HS and TTP. So both HS and TTP will have thrombocytopenia and microangiopathic hemolytic anemia and the presence of these craniated cells or schistocytes in the peripheral blood. And depending on whether the kidney or the CNS symptoms prevail, you can distinguish between HS and TTP. And mind you, it's not only present in the renal, the CNS, and the blood, but also in other systems of the body, the cardiovascular, the gastrointestinal, and pulmonary. And this is the paper by Norris and Murzi on the cardiovascular complications in atypical hemolytic uremic syndrome. So to sum up, the cornerstone of pathogenesis is endothelial damage, platelet aggregation, and microvascular bed occlusion, with the consequences of microangiopathic hemolysis, with hemoglobin decrease, LDH elevation, haptoglobin decrease, schistocytosis, and a negative process, with thrombocytopenia and ischemic multi-organ failure. Now it became clear that you can also distinguish pathogenetically between HS and TTP on the basis of the presence of or absence of activity of ADAMTS13, which is a protease inhibitor and degrades von Willebrand factor. And you know, when there is blood flow with the shear force, you get unfolding of the ultra-large von Willebrand factors. And if this is not cleaved by ADAMTS13, it's going to attract platelets and form platelets and bile. But this is not the case with, of course, to have a significant reduction in ADAMTS13 activity, it should be less than 10%, because you can have relative reduction in other conditions. And this is not the case with HS. In HS, if you look down here, you see this is the usual alternate pathway activation, which is continuously activated to form the C3 convertase, C5 convertase, activating the terminal components and resulting in hemolysis. And this is very good when it comes to pathogens. But this is not good for our cells in the body, so they have to be regulatory proteins. And we have the complement factor B and complement factor I. They are present in fluid media, and the membrane cofactor proteins, which is a membrane-attached regulator, and these are very important to prevent the occurrence of this problem. These are deficient in HS, and the deficiency could be due to genetic mutations, and there are 100 different mutations that are available. And this is genetically determined, of course, or we can have it to be acquired due to the presence of autoantibodies. So you think you now know the diagnosis, and actually this is just a start, because this is only the pathology, and behind this pathology lies a big list of causes, and we have to be able to distinguish between different causes, because sometimes treatment of the cause will cure the conditions. And this is a very important slide, because now TMA disorders are classified by molecular mechanisms into ADAMTS13 deficiency mediated and complement mediated TMA that we've just been talking about, and these could be either inherited or acquired, as mentioned. But we also have the drug-mediated TMA and the cetotoxin-mediated TMA, which are acquired, And we have the metabolism-mediated TMA due to defective intracellular metabolism of vitamin B12, cyanocobalamin, or coagulation-mediated TMA due to genetic mutations in the genes coding for proteins that are important for coagulation, like the thrombomodulin and plasminogen. And to make things more complicated, we have secondary causes that themselves can produce thrombocytopenia, microangiopathic hemolytic anemia, and they can trigger the activation of complement-mediated and ADAMTS13-mediated. So it's very important to know what you're dealing with. So for the diagnostic approach, whenever we have this triad of renal dysfunction, thrombocytopenia, and microangiopathic hemolytic anemia, we have to take a thorough history and physical examination. And if those patients, after examination and provisional investigations, we still don't get an obvious cause, then we have to consider complement-mediated TMA and ADAMTS13 deficiency TMA, not just to consider, but we have to start treatment while waiting for the results for ADAMTS13 activity measurement. The reason for that is this takes a long time, and knowing that the mortality is more than 90% if untreated with the TTP and less than 20% treated, and because several types of assays are used and they yield conflicting results. For this reason, the diagnosis of TTP remains clinical diagnosis supported by the results of the testing. Also, patients with complement-mediated TMA, such as particularly those with postpartum acute kidney injury, they may require treatment because they can progress very quickly to end-stage renal disease, and if anti-complement treatment is available, this is going to be a good choice. If not, of course, you can still go for plasmapheresis. So the first step is to exclude drug-mediated TMA, and this is something that we can do it from the history, and there's a big list of drugs, including those used for cancer therapy and other drugs, and the mechanism is either through immune-mediated mechanism where antibodies against the drug cross-react with other cells in the body, and quinine is one of these drugs that's not only present as a drug, it can be present in beverages, like, for instance, the bitter lemon or soda water, so this is very important to take a very good history. And we have also the dose-dependent toxicity mediated either acutely, if the patient receives a big dose intravenously, for instance, or gradually, like the patient is on certain medications for weeks or months. And the most important core groups are the chemotherapeutic agents, immunosuppressive agents like calcineurin inhibitors and tacrolimus, and vascular endothelial growth factor inhibitors like the sirolimus, and narcotics, particularly the illegal ones. Now, the second step will be to exclude the secondary causes, and this is also very important. And the first thing to do is, a very quick test to do is the Coombs test, because this is going to exclude the autoimmune hemolysis, Evans syndrome. And another thing we can do quickly to exclude DIC, which can mimic TTP, is to do the coagulation profile, because coagulation profile is basically normal in TTP. It's going to be abnormal in DIC, and there's going to be an increase in fibrin degradation approaches. Now, if you go through the secondary causes, you have autoimmune diseases like lupus nephritis, acute scleroderma, catastrophic antiphospholipid syndrome, vasculitis, infections, viral, bacterial, and fungal, pregnancy-related, malignancy-related, transplant-related, and malignant hypertensions. So all these have to be considered. For instance, if your patient has a systolic blood pressure more than 200 and diastolic more than 130 mm mercury, and this condition can resolve by controlling the blood pressure. And if you suspect an autoimmune disease, you go for immune profile, and treatment here is going to be immunosuppression. And if you suspect infections, you go for microbial testing, and there is a big list of pathogens that can produce this picture, and treatment here is going to be antimicrobial. And if you suspect malignancy from the symptoms, you go for tumor markers and more in-depth imaging techniques, and the treatment here is going to be treatment of malignancy. And then we have the pregnancy and the transplant-related. If we have time, we can go more deep in that. But then the second, or the step number 3 is going to exclude the Shiga toxin-mediated. And this is also can be excluded from the history because in this case, it usually affects children but can affect adults. And it produces watery or bloody diarrhea due to E. coli, Shiga toxin producing, and Shigella dysentery. And the toxin is directly toxic to the endothelial cells, in the podocytes and mesangial cells of the kidney, and they also activate the alternate complement pathway. And this can occur sporadically, but can occur in epidemics due to contact with the farm animals or due to undercooked meal, as occurred in the United States. or contaminated water, as for instance here occurred in Spain before. And the treatment is going to be a general supportive treatment with intravenous isotonic hydrations that can limit the severity of AKI and the need for renal replacement therapy. There is no role for anticoagulation, no role for anti-motility drugs, and no role for antibiotics, except perhaps in the presence of bacteria, Shigella dysentery type 1, and azithromycin had some role in the German epidemics. Is there a role for plasma exchange? Actually, there are no prospective randomized controlled trials, but it can be used in adults with a combination of severe AKI and CNS involvement. Now, if you still don't find a reason, a clear reason, you continue with the investigations, and one important investigation to be made is the amylase, because TME has been reported to be associated with acute pancreatitis and sometimes occurring a number of days after resolution. And another thing is the thyroid function test because of an association between thrombocytopenia and thyrotoxicosis. Well, if you do all that and you still don't have an answer, then you have to suspect the complement-mediated and ADAMTS13-mediated and try to discriminate between them, which is also very difficult on clinical grounds alone. Because they both have thrombocytopenia and microangiopathic hemolytic anemia. HIS has more of renal involvement, but still CNS involvement can occur, and TTP has more of CNS involvement, but again, you can have renal involvement, and there may be fever, and this pentat is not present in 60% of the cases of TTP. So we can differentiate by doing the ADAMTS13 activity. We'll differentiate the TTP. What about the HIS? Do you have to do any special tests for it? Actually, there is no requirement for identified complement gene mutations because in 30 to 50% of patients with atypical HIS, they have no identified genetic mutations. And there is no role even for complement level testing because testing can be unreliable and complement pathways can be activated in other disorders and levels are normal in most patients with atypical HS. ولكن يعني برضو في ناس recommend doing this testing, especially in children who have no Shiga toxin HS or adults with normal or moderately low ADAMTS13 deficiency and no other apparent reason or drug-induced etiology. In postpartum women with rapidly progressive acute kidney injury following delivery and patients requiring kidney transplantation. So the treatment is going to be by plasma exchange, and when to start, it should be started within hours, maximum 24 hours of diagnosis. It has to be started daily, and then you reduce gradually. You don't stop abruptly, and you stop when the platelets is more than 100,000, and of course other measures. There's no quite a consensus, but this is what is agreed upon. And plasma exchange is superior to infusion because it supplies larger amounts of plasma while avoiding fluid overload. It removes the mutant, the complement factor H and ultra-large von Willebrand factor, and it removes antibodies in the secondary causes, but the effect is usually transient. For this reason, you give, with the plasma exchange, immunosuppressive medications like steroids, azathioprine, mycophenolate, mofetil, and this allows long-term dialysis-free survival in 60 to 70% of the patients. There are also studies on rituximab. It's used after remission to prevent relapse and also in resistant cases, and it's very promising. And the caplacizumab for the acquired thrombotic thrombocytopenic purpura, which is caused by autoantibodies to ADAMTS13. So this antibody is directed against the ultra-large von Willebrand factor. It is in phase 3 trial and it's very promising. What does not work in TTP? Antiplatelet therapy alone. It may have a role with plasma exchange, and you should not use it with platelets less than 50,000. Platelet transfusion may worsen CNS or cause AKI and may be used in the preparation of invasive procedures. Splectomy is of no benefit unless accompanied by plasma exchange and steroids. What about the anti-complement, eculizumab? Again, when you have this combination, you might not need to do the test, or even if you do the test, they're not going to be immediately available. So if you can afford to get this drug, and then you can use it in children with no bloody diarrhea and no apparent cause, because this is going to save them besides the fact that it's very efficient, of course, it's going to save them the problems of transfusion reactions and catheter-related complications, and in postpartum women with deteriorating kidney functions. And pregnant women, when they have a pregnancy-related problem. It's usually resolved with delivery. If it continues and if it goes into progressive renal deterioration, so this is very much likely to be due to atypical HS. So this is the eculizumab, which is a humanized first-in-class anti-complement 5, and it inhibits C5 and inhibits the rest of the procedures, and there is no consensus on the duration of therapy, and of course the cost is prohibitive. And if it is going to be used, then the patient will have to have a diphtheria meningitis vaccine 2 weeks before the induction. It's given intravenously weekly for the first 5 weeks, then every 2 weeks thereafter. And now you have excluded the drugs, the shigatoxin, HS, and the secondary causes from the history and investigations. You excluded DIC, and you went to differentiate between TTP and HS. So what is really left is the inherited causes, metabolism-mediated and coagulation-mediated TTP. And again, in those patients اللي احنا مش عارفين ايه السبب عندهم، اللي هم الاطفال اللي ما عندهمش شيجاتوكسين HS، والكبار اللي ما عندهمش ADAMS 13 deficiency, you test for cobalamin C deficiency mediated TMA using measurement of serum, homocysteine, and methylmalonic acid. Because for cobalamin C deficiency TMA, treatment is going to include only high-dose hydroxycobalamin, betaine, and malonic acid, and it has a potential for substantial improvement. Do you go for gene screening? Actually, the role is not clear. Again, for those children with no shigatoxin HS and adults who have no significant production ADAMS 13 and have no other indication of a polar drug history, it can be done, and patients with TMA who have hyperhomocystinemia or malonic aciduria. Thrombotic microangiopathy in pregnancy is يعني بتاخد محاضرة لوحدها، لكن at least we have to differentiate between those with pregnancy specific, the preeclampsia and DIC from the TTP and HS. And of course the major clinical manifestations here will be hypertension and edema. With DIC you may have bleeding or infections, and for TTP we have urologic symptoms, mainly in HS we have renal symptoms. Coagulation studies will be abnormal in DIC. It's basically normal in TMA, but it's going to be variable in HELLP syndrome because of liver affection. Other things may be proteinuria and elevated liver enzymes with the HELLP, reduced fibrinogen, increased FDPs, and increased D-dimer with the DIC, and thrombotic ADAMS 13 deficiency with the thrombotic TTP. And of course the treatment here is going to be delivery. Here is going to be antibiotics, and here blood transfusions, and here is going to be plasma exchange. What about the thrombotic microangiopathy in kidney transplant patients? Well, again, you can have de novo causes due to drugs that are commonly used in kidney transplants, due to viruses, CMV, parvovirus, HCV, BK, and HIV viruses, due to antibody-mediated rejection and ischemia reperfusion injury. What's interesting here is usually more than one factors are existing, and also in 29% of those patients, they already have mutations. So it's like that some patients are genetically predisposed, and when there is a trigger, then the condition becomes clear. Or we can have the recurrent disease in patients with previous history of HS. So the treatment here, of course, will depend on the cause, and for those with the antiviral or you remove the drugs, etc., and for those with the recurrent disease, then there's going to be a place for plasma exchange and eculizumab. So I'm going to end with this slide. Sorry for the quality of the slide, but this is a very interesting slide from the up-to-date. If you have a patient with suspected TMA with microangiopathic hemolytic anemia and thrombocytopenia, the first thing to do is look at the underlying conditions. If there is an underlying condition, then you focus on this underlying condition. If not, then you look at the age. If it's an infant with a bloody diarrhea, then this is shigatoxin HS. And if there's no bloody diarrhea, then you have to go through the causes with mainly the genetic causes, because with children, there's not much room for these secondary causes. So you start with the complement-mediated, metabolism-mediated, coagulation-mediated, if it's the case of a child. And if it's an adult with no much of a kidney injury, then this is probably going to be a TTP. Whereas if there is a kidney injury, you look if it's acute or chronic. If it's acute, it can be anything, the things that we've been talking about. And if it's chronic, then you have to consider the drug-induced thrombotic microangiopathy, the toxic dose related. And thank you very much.
نشكر الأستاذة الدكتورة مي حسب الله على هذه المحاضرة. طبعا موضوع من الموضوعات المهمة، وهي حاولت بطرق مختلفة عشان نوصل للكوز، وازاي يبقى في عندنا دياجرام او سكيلتون ونمشي فيه ستيب باي ستيب، لأن الحالة لما بتقابلنا الحقيقة بنخش في دايلما ويتش في ويتش، وايه الكوز اللي ممكن يبقى موجود. فبنشكرك يا دكتورة مي على توضيح الصورة بشكل جيد ده.